So thank you very much, Dr. Madhu, for inviting me again. So what I will talk about is there a need to modify our radiotherapy fractionation for different molecular subtypes. We heard so much about the tumor board, different things, but what about giving radiation? So this is, many of us don't know. I also had forgotten, there was an old Beatles song, "It's getting better all the time." And they also had a line in that, "Can't go no worse." So if you think of the two things that I have to cover, one is radiotherapy fractionation, other is molecular subtype. So both are getting better. Breast hypofractionation, maximum randomized trials have happened in this, really evidence-based. What used to be when I was a resident, 50 grain, 25 fraction to 40 grain, 15, 3 weeks, then 26 grain, 5 fraction, 1 week. And in terms of molecular subtyping, estrogen receptor also is a molecular subtyping, we forget it. So that was the first molecular subtyping, I think, of any cancer, looking at the estrogen receptor. Then of course, progesterone receptor, then HER2 new, then you added Ki67. And then when we thought it is almost the best we can have, of course, the bottleneck was the Ki67, then we had Oncotype DX, and then there's one decision RT that I felt because that is specifically for radiotherapy, all others are for other things. And then of course, why I said can't go no worse, because now we are moving away further. We're trying to give only 1 fraction or 2 fraction radiotherapy and trying to add more and more markers. That's the way I think we have already hit the sweet spot, and we will probably get it wrong, and more patients will not be benefited. In fact, some of them could be harmful. So now we will look at these two things. So can we modify the breast fractionation based on the molecular subtyping? And I will focus mostly on the 4 types that we call luminal A, luminal B, TNBC and HER2, which is basically based on these 4 markers, because the data is on that. So this is one of the, more than 15 years ago, I wrote an editorial accompanying one of the major fractionation studies. So for non-radiation oncologists, the breast, the tumor cells, different tumor cells and the normal tissues, their fraction sensitivity differs in body. And based on that, radiation oncologists along with radiobiologists, we have devised different fractionation schedules. The standard is giving 2 gray every day, 5 days a week, 6 weeks, 7 weeks total, or 5 weeks. And if you give fewer doses and a higher dose per fraction, it becomes hypofractionated. So there are different, there are some tumors like prostate cancer where it can improve tumor control and with less toxicity than breast cancer. But mind you, when I wrote this, we have taken breast cancer as one disease. We all know breast cancer is not one disease. It's a group of diseases which happen in the breast. There are some common things, but a lot of things are very different. So that's where we will go back again to see how fractionation could be examined. So just briefly, I will talk about a few of the landmarks trial. The START trial, important ST in the START trial stands for standardization of radiotherapy. START A, START B. They looked at various things. So what the modern radiotherapy is based on this START B trial, which is 40 grain 15 fractions, and this used to be a standard fractionation in north of England, Manchester. So when they had to do, John Yanner is a good friend, they had to do this trial, they said, well, our standard is 14, 15, you compare your standard with ours, and they came out to be winners. So in the START B trial, whether you give 50 gray of radiation in 25 fractions over 5 weeks, or 40 grain 15 fractions over 3 weeks, you get exactly the same. Not only this, the late side effects and acute toxicity is also less. So you can't get anything which is really convenient and also better. But when we adopted this, in our institution as a routine, people had concerns, some of my colleagues, that because we have different patient population, more high-grade tumors, node positive, younger patients. So each of the subgroups which we see more commonly, younger patient, node positive, grade 3, or those who have chemo, in these START trials and the Royal Marsden trial, there were more than 1,000 patients. In any of the subgroup, you don't see even a hint that hyperfractionation is worse for this patient. Of course, some people are still not convinced, they say, because this study was done in England and Canada, so it was not there. So now I will show some data. Subsequently, the group, again led by John Yanner and others, they looked at another study of once a week 5 fractions of radiation compared with 50 grain 25 fractions over 5 weeks, because by then the START B trial results had not come. So the standard they chose was 15-25. And again, this study was not sort of powered to detect local regional control, but at 10 years, there was no difference and there were so few events and late toxicity and local regional control was same. Then this study, which is a fast forward study, first I am just telling you the studies and then I will show the impact of molecular subtype, if any. In this, by then in England, 40 grain 15 fraction had become the standard treatment in 3 weeks, and they now gave 5 fractions. From the fast study, they knew that 5 fraction given once a week is just about good, then thought why can't we give it every day for 5 treatments? And in this, this is a very typical Yarnell thought process. He makes a 3-arm study. No one else does 3-arm studies. So because no one really knows in radiobiology what is the fact. Okay, so it based on the iso-effective, the fraction sensitivity, this could have been correct or this could have been correct, and this turned out that 26 grain 5 fraction, which is 5.2 grain given daily over 5 days, this produced same results which I will show. So this is the results of that. So this was powered to have for a 1.6% non-inferiority between the standard 14, 15 and these two ultra hypofractionated. So we were calling it hypofractionated, that means 5 weeks we had reduced to 3, and ultra, that means 15 fractions reduced to only 5. So this is ultra hypofractionated. And at a median follow-up of 6 years, it was seen that both these arms were exactly the same in terms of local control. But what was seen that when we gave 27 grain, there was more of late toxicity, but local control was not improved. That's why 26 grain 5 fraction became the standard arm. And important, when we adopted last year at TMH, we adopted it as one of our standard fractionation for T1, T2, N0, N1. Basically, patient who fulfilled the study criteria, we adopted it as a standard fractionation. And we had more than 1,000 patients at risk in each of the arm of the study at 5 years. So, which is the data which you get from 1,000 patients at that time point. This is quite robust. That is what we had. So in this study, in the appendix of this paper, they have looked at local region and distant relapse by subgroup and including molecular subtype. But actually in this study, because in England the cancer is becoming early and early, so they excluded patients with the most favorable. So more than 60-year-old patient with a molecular luminal subtype A and low grade tumor, they were excluded. Even then the event rate was so low, they could not detect any difference between the molecular subtype. That's true, and they could not find any difference. Now the Canadian trial was done a little earlier. So they had because it depends era when you do the trial, the type of patient population you have. But this trial was done in node negative patient and they did not give boost. And this Terence Whelan et al. Reported first in 2002. And then again you had a 12-year update, that is also more than 15 years ago. And what they found that if you give whether 50 grain 25 fractions 5 weeks or you give hyperfractionated 42.5 to 16 fraction over 3 weeks, you get just exactly the same results in terms of local control, toxicity, etc. and there was no difference in survival. So this was, now this study they had kept the tumor blocks and subsequently some of them got together and they looked at, they could retrieve 900 and quite a lot, 989 out of 1231 patients they could retrieve the tumor blocks. And in addition to running just the ERPR, HER2 and Ki67, they ran some other tests also including hypoxia marker, cell proliferation and other markers. And this was done when these patients had a median follow-up of 12 years. And what is interesting to see that on multivariate tox modeling, the molecular subtype was the only factor predictive of local recurrence at 10 years, which was, and so luminal A this is luminal B and HER2, which is again well known. But important is that neither the grade of the tumor, the molecular subtype or hypoxia, it did not predict response to hyperfractionation. So the risk of recurrence in both arms, whether you had standard arm or hyperfractionated, did not return to that. So based on this, they said node negative because their patient study was done in node negative. All grades and molecular subtypes may be safely treated with hyperfractionated RT. And this is a very important study, although this is not a randomized trial done specifically to ask this question, but because these patients were stratified and they had the blocks and the long-term results. So this tells us a very important message that patients who have a high-grade tumor and those who have, this thing, they're not. Then there's some other studies. So this is from Korea. They had treated 300 odd patients with hyperfractionated and they had matched controls. And again, they showed that whether you treat patients with hypofractionation or standard fractionation, based on the molecular subtype, there is no excess. So hypofractionation is not worse for any particular subgroup of patients, which again is reassuring that okay, we are not harming patients by doing hypofractionation. Now, because there is no randomized trial, that's why I have to go first. Results from a randomized trial, we have taken subpopulation and matched pair. This again is basically patient who had hypofractionated after radiotherapy and then they were then matched and a median follow-up. All of these have a long median follow-up. What they saw that grade 3 tumors actually do better with hypofractionated. So in this and in standard fractionation they do worse. And there is a hint of this in some other studies, but it has not reached statistical significance. And prostate cancer we also see, and this is it makes sense because high-grade tumors are growing fast. So if you hit them quickly, repeatedly, basically you're increasing the intensity of treatment. So they may do better. Again, there was a Milan cohort which has been published recently. So they had more than 1,000 patients who had either hyperfractionated radiotherapy, and in this they did not compare. And essentially, what they saw, the effect of the molecular subtype was on the risk of recurrence, but it was not not correlated with the hypofractionation. This is an important study on more than 5,000 patients, close to 6,000 patients, stage 1 to 3. They were treated in the modern era, 2005 to 9 in North America, and 2/3 of these patients, 76% of patients had hypofractionation and others had standard fractionation, and a long median follow-up. And the type of patient basically reflected the real mix of a patient, luminal A, luminal A, etc. And what they find that at 10-year locoregional full and the entire cohort locoregional free survival was, as you would expect, around 97%. And it was significantly different in the different subgroups. Again, which is expected. We know that HER2 positive and TNBC, they have a higher risk of recurrence. But very reassuringly, there was no difference in the 10-year locoregional free survival between hypofractionation and conventional fractionation in any subtype. So we can't say there's one particular subtype, if you use hypofractionation, they will be worse off. So I think this, I personally feel that this is the most reassuring data after the Canadian study. But Canadian study was limited to T1, T2, N0, so this and no patient had boost in that. So this is one of the sort of critical reviews. I think what I like is that very little is known on the subtypes intrinsic radiosensitivity properties, but if it exists, it will be very minimal, okay? And if whatever it is there, we don't know how to exploit it. So very quickly I'll show what we have done in hypofractionation. Last ASTRO I presented the data. So we have the largest real world data of regional nodal irradiation. So overall cohort is of 2,000 patients, but I presented the data because that's what people want to know on nodal irradiation with ultra hypofractionated. So we were doing it for many years, but sparingly for few patients, elderly patients, small patients. During COVID time, so it became our standard fractionation. Everyone was getting just 5 fractions, and so it's an ambispectral. After this, it's a prospective registry. I'll just show the main thing. What I wanted to show that in our cohort, this is a real world data because what the type of patient you see in Tata Hospital. If you see, the median age is close to 50 and TNBC 22%, HER2 positive is around 27%. So this reflects what we see actually in real practice, and half the patients, most of the, because this was RNI cohort, so almost all of these were node positive patients, and 2/3 were locally advanced breast cancer. Treatment is also standard. And I won't go into the details of this because lack of time, and that is not relevant for this study. I just retained those slides. And we treated, including internal mammary nodes for ultra hypofractionated, around 200 patients, and rest it was only supraclav, and of course breast and or chest wall was treated in every other patient. And our most common technique was field-in-field technique, or what we call is inverse forward planned IMR. We could do this because we could get very tight doses to the brachial plexus. We made sure the brachial plexus never gets more than the prescribed dose, and our heart doses were really very good. So because our physicists have been doing and they really became better and better. it was very excellent. It allowed us to treat all the patients without interruption. The word just starts and gets over. Very little toxicity. Even late toxicity at 2 and 3 years is not there. So this is the updated results my colleague Dr. Rima just sent me. So now we have a median follow-up of close to 40 months, and this is on the data of about 2,000 patients we have so far in the registry, because since last year we have again made our standard fractionation for T1, T2, N0, N1. And as you would expect in the type of cohort, the type of recurrences you will have. For overall survival, loco-regional free survival and distant metastasis free survival, again it correlates strongly with that molecular subtype. So HR positive, HER2 negative is the best, whereas T and BC is the worst and HER2 positive. So this is as you would expect. Fractionation we can't compare because all these patients are treated with ultra hypofractionated radiotherapy. And this is just to show, so the HER2 enriched and molecular and T and BC they are doing the worst as compared to the luminant types. I think I'll skip this. So what that I showed is basically the group. We have a large multidisciplinary group, and Dr. Rima, who's my colleague, she runs this unconventional fractionation registry. Thank you.
Thank you, sir. The topic is open for discussion. Any questions?
So, those who are doing conventional RT to the breast, they see that they can give the chest wall boost, and they claim that that chest wall boost adds to the success of their treatment. And there are others who are now practicing even alternate fractionation with chest wall boost. Is it a good thing to do with alternate fractionation chest wall boost or not?
So first of all, whether you should give a boost. In intact breast, the URTC trial we showed that if you give boost, especially in younger women, you improve the local control rates. For the chest wall, we have examined this matter. There are very few sketchy reports. MD Anderson had some patient, but there is no proper prospective data on that. So if someone is really at high risk, like margins close or positive, then only you give a scar boost, and maximum recurrences happen within 3 centimeters of the scar. And so we give a scar boost, but that is very sparingly we give. So it's an individual practice which does not have a basis. But if you are using hypofractionation, then also you can give a boost, because 14, 15 is the standard fractionation for us. So we don't ever give 15, 25 to anyone. I can't remember when we prescribed. Maybe for a sarcoma or something we gave 15, 20, others we don't give.
Okay, thank you, sir.
We know for sure that HER2 positive breast cancer is a molecular subtype which has got a differing sensitivity to radiation. They are relatively radio resistant. Intrinsic sensitivity is less. So, what is your policy, general policy, when you are giving the adjuvant radiation treatment? Whether you combine it with trastuzumab or whether you just give radiation alone. Because trastuzumab is potential as a radiosensitizer.
So we allow trastuzumab to be given. We have 1 or 2 cases of recall also, and quite people, but that is one odd case. So most of the patients have no issues, so we continue with that. And although their radial sensitivity may differ between HER2 amplified tumors versus others, but their fractionation sensitivity does not differ because the data that we have shown. So based on that, we do not change the fractionation, whether you should do standard or not, but we allow.
Sir, there is a recent publication of sequential treatment versus concurrent treatment on RT, and they found that concurrent treatment with HER2 and hormonal therapy is more beneficial than sequential treatments.
I mean, you are interrupting, very important treatment, anti-HER2 directed, which doesn't make sense. There has to be a specific reason to interrupt someone's HER2 directed treatment.
Now, in the practice, once patients who are HER2 positive, they will be receiving trastuzumab, and we never interrupt on trastuzumab while on radiation. That has been our practice.
No, also we don't interrupt any
radiation and plasma. Because now the treatment is mostly the 3 style. So one more dose, by the time next dose they finish the radiation. It's not a problem.
Okay. Thank you.
Thank you so much, sir. Now we move on to a session carryover from in the morning. Dr. Rajkumar Ramaswamy, sir, inviting you, sir, to deliver your session on TNBC, Forge a New Path, Precision Treatment Cuts the Math.